Hello, I'm Warren Hall, the National Manager of Support Services for the American Liver Foundation. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice and an ear for patients with liver disease and their families and caregivers. We do this through research, advocacy, education, and support. I want to welcome you to this installment of our Ask the Expert series. We developed this long-running series because we heard and continue to hear from so many people who say they forgot to ask their doctor a question during their appointment, or they realized on the way home that there was something that they really didn't quite understand and didn't ask for clarification. So we thought it would be helpful if we brought in medical experts so people can ask some of those questions, or that our experts may be able to help them to understand some aspects of their disease or treatment plan. Now, I always preface these discussions by saying that our guests today are not our personal physicians, so they may not be able to speak to your exact situation or tell you what to do. Only your own healthcare team can do that. But hopefully during this time together, we'll get a better understanding of the complexities of PBC and some of the new things that are on the horizon. During our session today, we encourage all of you to write your questions in the chat box below. Don't wait until the end so we don't run out of time. Now, some of you have already sent in your questions when you registered, and so we'll be presenting those to the doctors as well. And finally, we would like to acknowledge our sponsors, CymaBay Therapeutics and Intercept Pharmaceuticals, for their support of this program. Now I'd like to introduce our two wonderful guests that we have with us for this session. First is Dr. David Assis, who will be making a presentation to start us off. Dr. Assis is a hepatologist who treats patients with liver and digestive diseases at Yale Liver Clinics and Yale New Haven Hospital. He's also co-director of the Yale Autoimmune and Cholestatic Liver Disease Program. His focus is primarily on autoimmune liver diseases, such as autoimmune hepatitis, PSC, and our topic tonight, PBC. Also with us as a special twofer during this program, we have Dr. Marina Silveira. Dr. Silveira received her MD from the Federal University of Rio de Janeiro, Brazil, followed by many internships, residencies, and fellowships at the Mayo Clinic in Rochester, Minnesota. Dr. Silveira's clinical and research areas are also autoimmune liver diseases. She's developing clinical trials, translational research projects, and outcome studies to improve the treatment and multidisciplinary management of patients with chronic cholestatic liver diseases. Now, what jumps out at me as both of these biographical sketches is how many times the word patient appears. Nearly all of what our guests tonight do is patient-oriented, which is why we're so grateful for them spending their time with us today. So Dr. Assis, we'll start with you and your take on PBC and where things are now in research and treatments.
Thank you very much. Hi, everybody. My name is Dr. David Assis, and along with my good friend and colleague, Dr. Marina Silveira, I think we both want to thank the American Liver Foundation for the opportunity to have this session and to speak tonight. We hope that it is an interactive session, and as part of this Ask the Experts or education series, we hope that we can give you some information and share some of our thoughts, as well as some recent advances in the care of patients with primary biliary cholangitis. So once again, thank you for the opportunity. I thought that what we should do in terms of a general outline is to first put us all on the same page, perhaps just discuss briefly some of the basics of the liver and of liver disease, Obviously, our session is focused on PBC, or primary biliary cholangitis, so we'll go over some of those details, new studies, and then we had received in advance some questions from patients through the ALF, and you may have other questions of your own, so hopefully we'll have plenty of time to discuss that as we go along, and certainly at the end. So why don't we start then just by briefly reviewing the liver and its functions. So we know that the liver, which is on the right side of our abdomen, right upper side, is the largest organ, solid organ in the body. A healthy liver can weigh anywhere from 1,400 to 1,600 grams, so it's quite large. And it's a very complex mix of all sorts of tissues and cells, blood vessels, and important for our discussion today also is the source of bile. The liver, as I'm sure you know, has a key role in metabolism and keeping us healthy, and also very helpfully has an amazing capacity to regenerate, even after severe acute or even chronic injury. The liver receives its blood from the intestines and through a main vessel called the portal vein, as well as a smaller amount of blood from the hepatic artery. And if you think about where the liver positions itself within the body, the liver is receiving, quite a tremendous amount of blood that's drained from our intestines. And that means that the liver is receiving material from the outside world on a constant basis. So it has to both protect us, but also to metabolize all of these nutrients and sometimes even toxins that are coming in from the outside world. The anatomy of the liver on a microscopic level, then, this is a very helpful cartoon, I would say. It gives us a sense. There's something called a portal tract, which includes an artery, a vein, and a bile duct. The liver cells, also called hepatocytes, make bile, as well as many proteins and detoxifying functions. This bile then, and bile acids in particular, need to get out of the liver once they're made, and they travel through these little sinusoids and bile ductules, I should say, into the bile ducts. And just like a tree in winter, the small bile ductules become larger bile ducts and then very large bile ducts until the bile then empties into our intestines. The bile is made by the liver, but the liver is not made to harbor bile. If bile cannot get out of the liver, or if the liver is having trouble for any reason getting rid of it, or there's a blockage, for example, liver can be retained. The bile can be retained in the liver and cause problems, which we will discuss in the context of PBC. This is just an example to show you a slide from the liver. This is a biopsy slide, a very healthy liver, I should say. Here's the hepatic artery on this lower portion here. Here's a very nice happy bile duct with the bile duct cells called cholangiocytes, which are draining that bile on a 24-hour basis, 7 days a week. And then the portal vein here, which is also the way in which a lot of that blood from the intestines arrives in the liver. So as I mentioned before, the liver removes toxic substances from the environment, and as well as helps us tremendously with metabolism of nutrients, for example, in the diet. It also prevents infections by trying to remove any infectious particles that are coming in through the outside world and might be absorbed. It makes most proteins for our body. The liver helps to maintain adequate levels of sugars, minerals, and vitamins. Produces key blood clotting factors, which are essential for our livelihoods, and also makes bile. As I mentioned, the bile digests foods, helps us with absorption of vitamins, as well as influencing metabolism. However, that bile needs to be produced and then get out of the liver for proper functioning. What is then cholestasis? Well, cholestasis is a harmful retention of bile in the liver, and it can come from a variety of sources. If you have a bile duct stone that will keep the bile from draining to the intestines, that can cause a backup of bile. If there's something wrong with the liver cells and how they process and make the bile, that can be another source of retention. Or if the bile is made and tries to get out, but little microscopic bile ducts are getting harmed, and that can lead then to bile to be retained. You can see in this slide, in comparison to one that I showed at the beginning, how there's these little orange or dark brown substances. This is actually bile, which is stuck in the liver. And this creates a condition called cholestasis. Some of the key labs that we look at to help us understand if the liver is being harmed in this way are one enzyme called alkaline phosphatase, or ALP, and another one is called GGT. And these are key labs that we use when trying to understand if the liver is suffering from cholestasis. no matter what the cause of liver problems, be it hepatitis, cholestasis, or other injuries, what we really don't want in a chronic condition is the accumulation of scars, also called fibrosis. And this can occur as a result of inflammation and injury, again, from a variety of causes. You can see here in this cartoon that as opposed to a very nice open interface between the blood coming in through the blood vessels and then making its way to the liver cells, here in this cartoon on the bottom right, we have these scars which are preventing that interface. This then over time, if this becomes severe, can lead to what we call cirrhosis. Cirrhosis would be severe scar tissue in the liver from a variety of causes. One question then is, how would we know if there is fibrosis or scars in the liver? Well, a liver biopsy has traditionally been the best way to determine that. And that is a classic way of looking for the degree of scars through a variety of staging systems. But more recently, we have new tools which are non-invasive, one of which is called transient elastography or FibroScan, which is shown on the bottom left corner here, where an ultrasound-like machine will have some waves that go into the liver and tells us about the liver stiffness. This can help us to understand the amount of scar tissue in the liver without needing to do a biopsy. And more recently, MRIs can help us to accomplish the same thing. On the bottom right-hand corner, you see what we call MRI elastography, which is similar to FibroScan, except that it takes a composite of all the areas in the liver to give us an average to see how stiff that liver is. So these are some methods that we can use to understand fibrosis or scars. As I mentioned a minute ago, no matter what the cause of liver injury, what we don't want to see is progression of the liver from mild scar tissue to more intermediate, advanced scar tissue, and ultimately to cirrhosis. And the goal when we're taking care of patients with PBC is to either prevent the development of cirrhosis, or if it's present but early enough, to try to stabilize things so that there is no progression to further complications. It's important to prevent cirrhosis because studies have shown for a number of years that just having cirrhosis, even if it's not having active liver failure, is a risk factor for eventual complications, be they cancer or, for example, a need for transplant itself. So if cirrhosis is not present at the outset, it's very important to try by whatever means to halt that progression. And furthermore, if there is an early case of cirrhosis, what we call compensated cirrhosis, which is where the liver has the scars, but the function of the liver remains intact. It's still doing its daily job of making proteins, detoxifying the blood, getting rid of bile. That is a controlled state for cirrhosis called compensated. What we don't want to see is the liver starting to slip or to fail, which is called decompensated cirrhosis. And this can be complications such as bleeding, infections, fluid overload, and encephalopathy or troubles handling ammonia. Why am I saying all this? Because we don't want to get to those complications. And so our goal in diagnosing and managing PBC is to deal with and prevent significant fibrosis. So progression of fibrosis can be stopped and in many cases even reversed over time, not in all cases, but in many cases, if the underlying problem can be diagnosed and controlled appropriately. And sometimes that's easier said than done. There are some liver conditions for which we just lack the tools to make a proper diagnosis. And we have some diseases which we don't have any therapies that are shown to be effective. But in the case of PBC, as we'll discuss the next few minutes, we fortunately have therapies. And although they do not work perfectly for some patients, we have new studies coming down the pike which should help us to address even those unmet needs. PBC then, or primary biliary cholangitis, is a rare, chronic, autoimmune liver disease caused by a loss of tolerance by the immune system. We don't know why patients get autoimmune disease in general, similar to lupus, similar to rheumatoid arthritis, some forms of thyroid disease, but in this case, the immune system is attacking the bile ducts in the liver. This leads then to slow destruction of these microscopic bile ducts, as you can remember from that cartoon that we showed. It is the most common cause of intrahepatic cholestatic liver disease. In other words, retention of bile in adults And in fact, it has been estimated to have an incidence of up to 1 in 1,000 women over the age of 40. It can lead to cirrhosis and a need for liver transplantation, particularly if it's not caught early enough or treated. But many, not all though, of patients who are identified early enough can respond to treatment, although importantly, and we'll talk about this throughout our session, response of the liver to the inflammation sometimes does not lead to improvement in symptoms. And so I think we can all recognize that some of the symptoms of PBC, particularly fatigue, but also itching or pruritus, are not always addressed in an optimal way. So we have a lot more work to do. This is what a liver biopsy would look like in a patient, for example, with PBC, as opposed to that nice round tube of the bile ducts. This bile duct, which is shown here by the arrow, does not look very happy. It's being squished by this infiltration of immune cells, which are attacking it and causing some scars as well as inflammation. And again, the liver is meant to have the bile drain through this bile duct. And if that cannot occur, that leads to retention of bile and ultimately to scars, but also to some of the symptoms. One of the things that sometimes is a little difficult to understand initially when we talk about PBC is that it often has been present for a long time before diagnosis. The reason for that is that many patients who are starting to have bile ducts that are destroyed by the immune system do not have any symptoms at this stage. Perhaps they will have some fatigue, and when the bile retention becomes significant enough, very commonly some itching. But earlier on, this process often has no symptoms. As the bile ducts start to become lost or at least damaged sufficiently, the retention of bile increases, and very commonly at that point, then symptoms occur. Clearly, we would like to make the diagnosis of PBC as early as possible because that would give the best chance for the liver to respond to the available treatments. What are the symptoms of PBC? Well, as I mentioned earlier, some of the most common symptoms include fatigue, which according to some studies are present in at least half of the patients with PBC, and itching, also known medically as pruritus, which is present in at least a third of patients. There are other medical conditions and medical findings, though, that often go along with PBC. And in particular, other autoimmune diseases. As I mentioned earlier, PBC is an autoimmune disorder, and many patients with PBC or their family members may have other associated autoimmune conditions. Thyroid disease, a condition called Sjogren's disease, which is characterized by dry eyes and dry mouth, is also found commonly in patients with PBC. Celiac disease is more common in patients with PBC compared to the general population. And then a smaller number of patients with PBC can also have a different form of autoimmune liver injury called autoimmune hepatitis in what we call an overlap syndrome. Other findings in patients with PBC can include elevation of their cholesterol or lipids. This is in part because of the difficulties in processing the bile, since lipids and cholesterol are made in a similar pathway. Bone disease, we know that in addition to age-associated thinning of the bones or osteoporosis, patients with PBC more commonly can get osteoporosis, and so it's important to screen for that and supplement with vitamin D and further treatments if needed. And as I mentioned earlier, untreated or undiagnosed PBC can lead to cirrhosis and liver failure. How is PBC diagnosed? Well, the recent practice guidelines from our main American Liver Society have made it crystal clear how physicians and practitioners in general can make this diagnosis. If a patient has an elevation of that one liver enzyme called alkaline phosphatase, or ALP, for 6 months or more without another clear explanation, in the presence of an autoantibody. These are antibodies in this case called anti-mitochondrial antibody, or AMA, that for some exquisite reason seems to be highly associated with PBC. So it's a relatively specific autoantibody. So having an elevation in that cholestatic enzyme, in addition to an elevated AMA in a woman, for example, would be more or less sufficient for this to be a diagnosis of PBC. Not always are all of these conditions present, and there still is a role in some patients for a liver biopsy. And as I showed a minute ago, destruction of those microscopic bile ducts by the T cells or lymphocytes in the liver would go along with that. Now, there are a small number of patients who have PBC, but do not have this very specific autoantibody called AMA. Some recent tests have shown and studies have shown that two other autoantibodies can be tested for, SP100 and GP210, which may be present in about 5% of patients, but more or less, and it's important to remember these criteria for diagnosis. Now, the first thing that we should talk about when we talk about innovations in PBC is just to go backwards before we go forwards and realize where we were 30 or 40 years ago. I think it helps to put everything into perspective, frankly. One of our mentors here at Yale has told us several times that when liver transplantation first became more routinely available in the early 1980s, PBC was the most common indication for liver transplants. And thank goodness that no longer is the case. And this study from 1983 then, looking at the clinical course, the course of PBC, showed that when patients started to develop symptoms, be they jaundice, yellowing of the eyes, or itching or fatigue, the percent of patients who were starting to have cirrhosis and further complications would start to rise significantly. However, there is a medication called ursodiol. Now, many of you may be familiar with this, also called ursodeoxycholic acid, which is a very helpful medication that helps the liver get rid of the bile. It makes the bile more soluble, and it also helps to reduce the immune-mediated inflammation to a degree. This medication was studied then in the 1990s and was shown to have a significant benefit for patients with PBC, because ursodiol, by helping the bile to get out of those damaged bile ducts, was able to preserve the liver function, prevent scars from building up in the liver, and ultimately to prevent the development of cirrhosis and the need for liver transplantation. In fact, ursodiol was fully approved then by the FDA in 1997. And a very beautiful thing, I think, at least in medicine, is shown here on these graphs, both in the United States and in the UK over the next 20 years, or from 1994 through 2014, as shown very clearly in this study with the red bars. You can see that the number of patients who got listed for liver transplantations had a significant drop. In other words, patients were not getting so sick from cirrhosis that they needed to go to transplant. Now, this doesn't affect all patients. If a patient is unfortunately diagnosed too late or is in the smaller category of patients who do not respond to ursodiol, patients still do require transplant on some occasions, but earlier identification of PBC and treatment with ursodiol already has had an impact on the number of patients who need a liver transplant. And obviously that's a very good thing. Now, there are all sorts of fancy criteria, which we won't review here, for how to know if you or the patient is responding to ursodiol. This is used both in clinical care in our clinics, but also in research studies. So this has been a highly developed field over the years. We also know that some patients, though, do not respond as well as the rest of the patients with PBC. And in particular, I just want to highlight the fact that Hispanic patients with PBC seem to remain, for reasons that are not fully clear, at a higher risk of progression and may have a lesser response to the therapies that we have available. Whether that's driven by genetics is not quite clear, but we have seen in our clinics a higher percentage of patients, sometimes of Hispanic background, who are not fully responding to treatment. And so by no means do I want to imply that treatment is successful for everyone, and we have to keep our ears and eyes open for ways to identify non-responders early on. This brings me then to some of the unmet needs in this condition. Well, whereas I mentioned that most patients will have a response, and this response is very helpful in preventing progression of scarring, anywhere from 30 to 40% of patients will either not respond to ursodiol at all or will not respond sufficiently. Second of all, the unmet needs in PBC are very important to realize that they often relate to quality of life. This is not adequately addressed by our current therapies, which are centered around helping the liver to become less inflamed. So I would say out of all the unmet needs in this condition, one is to optimize our ability to treat those patients who are not sufficiently responding to ursodiol. And second, to come up with strategies, be they pharmacology strategies or other creative solutions to impact the reduced quality of life in this disease. Some of you may be familiar with a medication called obeticholic acid, or OCA. This is a different category of medicine compared to ursodiol. And in a study from around 5 or 6 years ago, it was shown to reduce the elevation in alkaline phosphatase, again, that lab measure of cholestasis, in patients with PBC who were not responding sufficiently to ursodiol. It was a successful study. Therefore, the FDA approved this medication for use in PBC about 5 years ago. Some of the potential downsides, though, of this medication is that in some patients, it can actually increase the amount of itching. Not all, but it can increase the pruritus. And unfortunately, it was discovered that in patients with advanced cirrhosis, those who were starting to have complications of the cirrhosis, were not responding very well to this medication with side effects. So therefore, this medicine should no longer be used in patients with advanced cirrhosis. But there are some other categories of medicines that have shown a lot of promise, and I think we will spend a few minutes on this because this brings us to some of the currently ongoing studies which are looking for new therapies. There's a category of medicines called fibrates, which are agonists of a receptor called PPAR. Fenofibrate, which is a medicine that's been approved for decades for treatment of high cholesterol and high lipids, was discovered in a very serendipitous way to have an anti-inflammatory property to the bile ducts. This has been studied in the lab and also in the clinic, leading to a lot of excitement that this category of medicine called fibrates may be helpful for patients with PBC who are not fully responding to ursodiol therapy. There is a medication that's related to fenofibrate that's used in Europe called bezafibrate, which is not identical but similar in many ways to fenofibrate. And then two medications which we will discuss in greater detail shortly called seladelpar and elafibranor, which are being tested actually as we speak in phase 3 studies. I would like to bring to your attention a very insightful article that was published in the New England Journal of Medicine about 3 years ago. Some colleagues of ours over in France performed a large study comparing the addition of a fibrate called bezafibrate to placebo when added to ursodiol in patients who were not fully responding to urso. And they reported wonderful outcomes in that bezafibrate, the addition of this medicine to ursodiol, led to a complete response, by which we mean significant improvement and even normalization of these liver enzymes in patients with PBC, who are the harder ones to treat. In other words, they are not as responsive to the usual medicine. So it was a very successful study showing that fibrates may have an important role to play in this condition. As a result of this, and the prior study of obeticholic acid, the recent practice guidelines that went into our Liver Society recommended that in patients with PBC who were inadequate responders to ursodiol, all called UDCA, they should be considered for treatment with obeticholic acid, starting at 5 milligrams a day. And fibrates can also be considered as an off-label alternative for patients who are not responding to ursodiol. Now, there was a recent update earlier this year, getting at what I showed you a few slides ago, that in patients with advanced cirrhosis, it was discovered that these patients should not take obeticholic acid due to some complications. So that was a recent update that we should all keep in mind. I will say that the use of fibrates is currently limited, though, by the fact that fenofibrate, as an example, is not a medicine that is labeled, so to speak, for use in PBC. And bezafibrate, which is available in Europe, not in the US, is also historically not been labeled for PBC. So how might recent advances and studies for PBC capitalize on the promising drug category of fibrates? Well, there are two studies, not only performed in the US, but also abroad, that are attempting to understand this better. And I would like to ask my colleague, Dr. Silveira, if she would like to discuss a little bit some of the characteristics of these studies, because she is a key investigator in the national studies here at our center at Yale. So, Dr. Silveira.
Thanks, Dr. Assis, for the presentations. Very, very interesting so far. And I like to echo your comments in the beginning. I'd like to thank the ALF for inviting us to participate in putting this important program together. And we're very excited to be participating at Yale of these clinical trials, because clinical trials are a very important treatment option for patients with PBC who are not responding well to URSO. Usually the treatments, when a person does not respond well to URSO, you want to add to the treatment, not to substitute. Usually the URSO continues. And these two phase 3 trials have both been quite encouraging. They're both multi-center trials, meaning that they occur in many centers across the country and across the world. And in general, patients with PBC from ages 18 and 75 are included. And like Dr. Assis mentioned, those who are on treatment with URSO but have not responded, meaning their alkaline phosphatase is still elevated. So 1.67 times the upper limit of normal is usually around 180 or a little bit higher than that. So that's usually the main thing that will tell us that you're not at higher risk of having more complications of PBC. So those patients, and of course, there's always some other things that we want to see. Most of the patients who already have very late stage disease, so the decompensated cirrhosis, like Dr. Assis explained, are not included in these trials. Patients who already had a transplant are not included. And of course, we want to be able to study the effect of the new medication on the liver. So in general, patients cannot already have a different type treatment other than the URSO. And there are a few patients, about 3 to 4% of patients, who have a lot of side effects with URSO. Fortunately, that's very rare, but some people cannot take it because they might have excessive diarrhea, excessive bloating, and very, very rarely even hair loss. So those are patients that can also be included in these trials if they've been off URSO for greater than 3 months. So both studies are enrolling about 150 to 180 patients across the world. They're similar, they're slightly different receptors, meaning they're all in the same family of the fibrates, but will work slightly different, and will be very interesting to see what these studies show.
Thank you very much, Dr. Silveira, and hopefully toward the end of the session, we'll be able to open it up for any questions patients may have. I think we got some questions submitted earlier before this discussion about clinical trials, and I know there's a lot to chat about, and so we're very excited to have that opportunity. I will then move on to discussing some of the bothersome symptoms in PBC, because clearly from a quality of life standpoint, it can be a challenge to live with PBC, even if liver enzymes are responding to therapy. We are very well aware as physicians of the discrepancy sometimes between the improvement in liver inflammation, but a lack of improvement in symptoms. And loud and clear, this is a focus that needs to be had so that we can improve quality of life in PBC. And that brings me to fatigue. It can be the most disabling symptom of PBC. And unfortunately, it has not been the focus of many therapeutic trials historically. That is changing, and for very good reasons. But we know that there is an unmet need in addressing fatigue. It can be severe in up to 40% of patients with PBC. It can be stable over time, whether or not the liver progresses. And as I mentioned before, even patients who are responding to ursodiol may still have significant fatigue. And at its worst, it can lead, and this has been studied particularly in the UK, can lead to a sense of social isolation and just severe reduction in quality of life. An interesting study from 2013 even suggested that severe fatigue does not entirely go away even after liver transplant. And I think some of us interpret this type of information to suggest that it's the immune system in the end that is causing the fatigue in PBC, because even with the new liver, the immune system remains the same. And so clearly the ways in which the body gets fatigue from PBC are not fully understood. One study from about 12 years ago showed impaired exercise tolerance in patients with PBC, meaning the ability to exercise, to move the muscles, and to have aerobic function was reduced. And this seemed to be related again to some of the immune-mediated markers, including antibodies. One study that was published about 3 years ago unfortunately had a negative result. It was not able to show an improvement in fatigue, and this was a medicine to help treat the immune system called rituximab. There was a lot of hope this therapy would be able to reduce the markers of the immune system that cause fatigue. Unfortunately, it was not a successful study. Now, Dr. Silveira, my colleague, had done a study a few years ago when she was at Mayo Clinic on a medicine for narcolepsy called modafinil. And I think it was a very interesting construct for the study because that medicine has been used effectively in patients with fatigue. My interpretation is Dr. Silveira took such good care of patients with PBC and the controls that everybody improved. Unfortunately, the result from the study, though, is that modafinil did not meaningfully improve the markers of fatigue in patients with PBC. So we clearly are still searching for effective medicines that can, or approaches, frankly, that can help with this. And this brings me to one very creative and innovative approach that Dr. Silveira is taking. And quite honestly, I think it's also something that should be recognized, that the American Liver Foundation has seen value in this, has funded it as a project to help patients with fatigue and PBC through an intervention based on mindfulness. And maybe I'll ask Dr. Silveira to describe briefly some of the characteristics of this study. We have shown that medications thus far have not been effective, but there are other ways, hopefully, to change the body and some of these pathways to impact fatigue.
Thank you, David. Yes, absolutely. We were very discouraged when I did that modafinil trial when I was at Mayo, because we were so hopeful. The initial studies had suggested maybe modafinil would be a resource for patients, but and it did help patients. But if the patients that were in the same trial that were actually getting the placebo pill, meaning a pill that had no medication in it whatsoever, they had the same good effects. So like in other studies, the medication that modafinil could give you side effects, but was no better than a pill that didn't actually have any medicines in it to make people feel better. And of course, that makes you think, what are the other things that can help people with fatigue that don't have side effects that are worth doing? And so one of the theories of fatigue and PBC is that there are changes from that autoimmune attack, so to speak, and from the bio backup perhaps, that are changing the brain and the pathway. So there's a central component of fatigue too. So try to modify that by interventions like mindfulness, for example, was something that we thought might be of benefit. So we have a current trial that where we intend to enroll 20 patients that have moderate to severe fatigue. So you'd fill out a questionnaire to try to quantify how much fatigue you have on average. And those patients go through this 8-week course of mindfulness intervention with other patients in the session. There's an instructor, and then we measure how the fatigue is before, after, right after, and then a few months after. And one of the things of the trial, we thought many patients were very excited about it, but the logistics is hard when you have fatigue. So we started off with an in-person study, but we found that a lot of patients wanted to participate and just could not physically do it. So after time, we recognizing that, modified this now to most of those sessions being over Zoom. But then of course, COVID hit, and then we're still now looking for our patients to participate. So if you have any interest, let us know. We will be happy to assess to see if the study is right for you. We had one first group that went through, and very interestingly, you could see here that these are the average fatigue scores that were very high when patients signed up for this study. We checked a little bit a few weeks before starting the mindfulness. There was a little bit of difference because fatigue, as you all know, can vary from day to day, from week to week. So there was a bit of variation, but you see here that there was a dramatic drop after the mindfulness-based intervention from 40 to 28. 28 is below that threshold of moderate to severe fatigue, and has that drop of more than 5 points has been shown to be meaningful in terms of how that impacts your life. And you can see here that not only it dropped right after, but 3 months later at time of follow-up, those scores were still low. It showed us that this can be a sustained change, and we're hoping that over time even more. And of course, now with mindfulness, there's apps, there's refresher courses, so hopefully it's something relatively easy to do that everyone could have access that might help them. And just to plug in, there was also a UK study, kind of a similar principle, but with exercise. And even though, of course, patients who have fatigue, they sometimes don't have the energy to exercise, but they did a program with guided exercise at home, and they also found benefits. So those are things you can be thinking that you can do that doesn't involve equipment, very simple, that could help you with your quality of life there.
Thank you, Dr. Silveira. Then moving on to pruritus or itching in PBC. Not all patients, but some patients have a significant amount of itching related to that retention of bile, and the mechanisms are not fully understood, but itching can be quite devastating for patients who are unable to function, unable to sleep. For mild cases, topical creams can be used. A medication that can cause some drowsiness called hydroxyzine is used also for mild cases. But if this symptom remains bothersome, again, along with therapy for the PBC itself with ursodiol and added therapies, there is a list of medications that can be tried. Honestly, as I tell my patients, we try one, and if that doesn't work, we sometimes try the other. I think everyone is very unique, and when it comes to these medications, we certainly want to be responsive to the patient's needs. There's no one-size-fits-all when it comes to therapy of itching or pruritus. Cholestyramine is probably the medicine that is used most frequently, and the key to this medicine, which I always find helpful to emphasize, that it should be given 20 minutes before a meal so that it can bind to that bile that is being excreted into the small intestine and help it to be eliminated from the body. That is the right timing to take it. And again, there's pheresis, which is a therapy in which the bile acids can be removed through a large catheter, which is a more invasive system, but that would be the extreme. I think this is certainly an area of management of pruritus or itching that requires a very close collaboration between the provider and the patient to see what's working and what's not working. It's interesting that we were talking about fibrates earlier, and this study that I'm showing here was not necessarily evaluated based on the current fibrates that are in clinical trials, although, as I'm sure Dr. Silveira will mention during Q&A, if asked, this is highly interesting to the existing studies also, which we'll evaluate. But a study called Fitch showed that patients who took, again, this bezafibrate, a fibrate that's available in Europe, had a significant improvement in their liver injury or inflammation, but also had a significant reduction in the itching or pruritus. So although it's a bit premature to know how the medicines available in the US, the fibrates, will affect itching or pruritus, I think we're hopeful that some additions of therapy may be coming that can both address the liver inflammation and the itching, something that up until now has not really been in sync, as I mentioned earlier. Lastly, then, there are still a number of patients who are either diagnosed too late with PBC or are the smaller category of patients who are not responding to any therapy. And so liver transplantation is occasionally still needed in PBC. And given that there's been a significant amount of interest to know what happens to the liver after transplant, what's very interesting but also difficult to understand is that PBC can come back after transplant. And one might be wondering how that's possible, since the liver transplant involves giving someone else's liver to the patient. But so it's a brand new liver, so to speak. However, the immune system remains abnormal still. And so overall, the recurrence rate of PBC after transplant has been quoted in the 25 to 30% range. However, this very helpful study from the last year in Journal of Hepatology shows that patients who got preventative measures with ursodiol after the transplant had a much reduced recurrence of PBC. So for patients who do still require transplantation for PBC, the message is quite clear. They should receive ursodiol from the beginning so that they have a significantly reduced risk of recurrence. Now, Dr. Silveira and I thought that we would quickly go through some of the questions that were already pre-submitted, and then after that, we'd be very happy to take some questions from the group. Someone had asked whether FibroScans or transient elastography, which is intended to measure the stiffness level of the liver, whether they are accurate in PBC. It's a very good question, and we wonder about that every day in our own practice. One very recent study that's still in press from hepatology, which was a study in multiple centers in Italy, showed that a stiffness level of less than 6.5 kilopascals, meaning a very, very mild or normal stiffness level, or a very high stiffness level, which is in the moderate to high range, greater than 11, that they were pretty accurate overall to either eliminate the possibility of significant scars, which would be the lower range here, or if above 11, to suggest that indeed there is a fair amount or a large amount of scars. So something that we keep in mind in clinic is we want to help to understand the extremes. If the patient has no significant scars or has a lot of scars, perhaps some of the stiffness values at the margins, so to speak, can be helpful. Interestingly, BMI, in other words, the relationship of height and weight, was not affecting these results, nor did the liver tests. So overall, I believe that elastography or FibroScan is a reasonable approach to determine who has either no scarring or minimal scarring and who has a more significant amount of scars in PBC. Another question was—
Sorry, I just wanted to
Sure.
plug in there, as you saw from that slide for how to diagnose PBC, you see that a lot of patients now, they just need the blood tests with the alkaline phosphatase and the positive AMA. So a lot more patients don't have a biopsy when they're first diagnosed. So a FibroScan can be a much easier way to find out more about scarring than going through a biopsy. And even if you did have a biopsy years ago, most patients don't want to go through that year after year again. So the FibroScan not only can be accurate in the beginning, but also can be a tool that we can use in addition to the other tests over time to see how things are changing and hopefully see that it's stable over time and give us that additional comfort level that the medication is working, then the numbers are good, that the stiffness is staying the same during treatment. And if it's not, again, identifying who are the patients who are higher risk and where you should be thinking about adding something else to your treatment.
I fully agree. Thank you, Dr. Silveira. In fact, the fact that this was done at diagnosis is very helpful to know what to expect or where things are at moving and also moving forward. Another question was whether it's possible for my liver, this patient question, to just stay compensated. I would say yes. And I don't know how you approach this question with patients, Dr. Silveira, in your practice, but you like to advise patients that if we see normalization, ideally, of the liver enzymes that relate to cholestasis, that we can be relatively confident that the liver will not progress.
Yes, David, that's always a great question from patients when we have them in clinic. And Heidi had a question in the box there, which was exactly the same. If you're taking medicine, if you respond, is it possible that you can stay without symptoms and do well? And the answer is absolutely yes. But that highlights also the importance that is not just get on the medication, do your blood tests, and then not think about it again. It's very important to follow up closely. So make sure you're getting blood tests every 3 to 6 months to make sure that response is there. Make sure to continue to take the medication even if you have the response, because unfortunately, even as good as URSO is, it is not a cure. Back in the 90s, right after the FDA approval, there was a shortage in the market, and we learned the hard way that if you stop the URSO, all of the benefits are gone until you're back and stay on the URSO. So it's really important to stay on treatment. But it is possible, particularly if you pick up on the disease very early, patients respond better when drugs are starting in the early phase compared to when you already have more scarring.
There were several questions that were submitted earlier about the role of diet, coffee, alcohol, supplements, medical marijuana, very frequent questions that we also get in clinic. I mean, from my own perspective, I wish we had an anti-autoimmune diet that was proven or shown to reduce the immune-mediated injury in the liver. We don't yet know that, but I think it's very clear that for overall liver health and health in general, keeping to a diet low on processed foods, certainly more geared toward Mediterranean style diet, is very healthy. In patients who have cirrhosis, it's extremely important to have a sufficient servings of protein, whether that's chicken, eggs, fish, beans. Protein is very important. But specific diets to alter the immune system are something that we're very hopeful in the years to come will be developed. Coffee has been shown in multiple studies, and I know there was years where this was a back and forth, but I from my perspective, the science as far as liver fibrosis or scarring is relatively settled now, which is coffee is actually beneficial for patients who have some liver scarring, that it seems to be associated with reduced scars. Alcohol is always a complex topic because of the relationship to socialization. As you can imagine, for me, anyone who has cirrhosis should not be having any alcohol. There is really not a role or I would not play any games with the liver that's already very fragile, frankly, and sparingly in patients who have PBC under control. Supplements and medical marijuana are always complex because there's so many, frankly. I don't believe we have great data behind supporting any of these supplements and medical marijuana. Certainly there are some cases of toxicity. So I don't know, Dr. Silveira, how you often approach this, because there is a lot of desire and interest, as there should be, in taking control of one's health and trying to make improvements, which is a very proactive and a good thing. You know, we want that to occur just by minimizing the risk of side effects.
Absolutely. The patients who engage actively in their care are the patients who do the best. And so obviously all patients are always thinking, what else can I be doing on top of using the URSO and coming to my visits? So obviously diet is very attractive, but it's very hard to study diet. And I think that's the main reason why we just don't have something that's really foolproof that's going to help you. So right now there's no studies that show that a change in your diet will substitute being on the right medications, seeing your doctor, and having good medical care. But as Dr. Assis said, you know, always fresh fruits, vegetables, Mediterranean type diet. If anything, it's been proven to be good for your heart health, which everyone can use. And it's very important. There are studies in PBC that show if you on top of the PBC have fatty liver, that puts you at risk to progress to cirrhosis faster. So having a healthy weight, avoiding fatty liver is really important in PBC. There are not diet per se, but there also are studies from a few years ago that show that patients who smoke, they can have progression of scarring faster. So it's not really diet, but it's a little bit of lifestyle. If you're still smoking and have a diagnosis of liver disease, particularly PBC, studies have shown you should not do that for your liver health. I agree with 100% with you, Dr. Assis, about alcohol. It's a big no-no if there is cirrhosis, and it's something that can be controlled. So There's no reason to say absolutely not in a patient with early stage disease, but be mindful of that. We don't really know what's the magic safe amount, so try to minimize that the best that you can. Supplements, there is not a whole lot of information. We do have studies on milk thistle that show that at least it is safe compared to many other things that have been shown to increase the risk of liver injury. So in general, we advise against supplements because not only you don't know, there's no proof, but some of the supplements might not have in the bottle what they say they have on the label. So you might be exposed to toxins that you have no clue about that could cause liver injury. So I think you mentioned this to me earlier. We're not against or in favor of milk thistle, for example, but in general, try to avoid supplements because they have some risk to almost like any medication. But I'm seeing here in the chat something that's very, very important. We're talking about supplements like, for example, milk thistle, SAMe, antioxidants. Now, in PBC, patients have vitamin deficiencies. They're more prone to having vitamin D deficiency, like Dr. Assis mentioned, bone disease. So many of those need to be checked periodically, vitamin D levels for sure. And if you see low levels of vitamin D, treat that. Calcium supplements for those without kidney stones can be very helpful. So there is a place for supplementation of some of these vitamins and minerals that a patient might be deficient in. Thank you for reminding us of that with that question in the chat.
Absolutely. That is very well timed. Thank you. One very interesting question was submitted prior to this talk, which is, can PBC be passed through the generations? Should I have my children screened? And if so, how often? Very interesting question. First thing I should say is that, fortunately, PBC seems to be a disease of adults for reasons that are not quite clear. It's extraordinarily rare, if ever, that PBC would develop in somebody who is less than 18 years of age. And so that is one reassuring aspect here, because we have other autoimmune diseases which most certainly can present in childhood, but PBC, fortunately, is not one of those. Now, this is an interesting question because patients who have one autoimmune disease often have other autoimmune diseases, and patients who have autoimmune disease often have family members with one or more autoimmune diseases. That gets to some of the genetic risk that probably is present that leads to the immune system getting overactive and losing tolerance. So the first thing I tell patients in my own practice is that they should be aware of the fact that autoimmunity can run in families. It may not be the same condition down the generations, but more commonly maybe thyroid disease or lupus or rheumatoid arthritis. But to the very, very great and specific question, there is actually a study, which I'm showing here from Iceland, published about 3 years ago. And in Iceland, because of the relative isolation, again, of the population, the fact that they can do epidemiologic studies, they actually looked to see, well, how commonly was PBC diagnosed in family members of patients with PBC. And interestingly, they showed that relatives of PBC patients had a markedly higher risk for development of the disease compared to controls. That was in first, second, and even third generation degrees of separation, of relatedness, in other words. So yes, PBC can be more common in relatives of patients with PBC, although I should emphasize that other autoimmune diseases are even more common. So this is certainly something to be aware of. What to do about it? Getting to that original question. Honestly, I typically advise against checking random autoantibodies, just trying to make a diagnosis, but simple liver enzymes such as alkaline phosphatase as part of a general physical once a year would be, in my opinion, more than sufficient to screen for that in any family members. I don't know how you counsel your patients, and Dr. Silveira, but it's a really good question that a patient submitted, I think.
It certainly is, and we hear that often in clinic. And so the closer the family member, the higher the risk. Particularly at high risk are sisters and daughters of patients with PBC. So I always counsel my patients, make sure but you share your medical diagnosis, because of course for them to know their family history makes them well equipped to talk to their own doctors and make sure that they have liver tests as part of their tests. Now, almost everyone these days, you go for your physical, you get the blood test. That's why we're finding more and more PBC at early stages, fortunately. But sometimes your liver numbers might be so mildly elevated that that poor primary care provider who doesn't see this condition often has, sometimes 20 minutes to see each patient, and they might, skip over that blood test that might be crucial to follow up with more tests at that point. So making sure that your family members are aware and that they can advocate for themselves if their numbers are a bit up, making sure that they have the next step done for them. And I do discourage against getting that AMA test, that blood test Dr. Assis was mentioning, the autoantibody, because we know that it is positive in some family members, and it doesn't always mean disease, not even at present or even sometimes not at future. So that could be very distressing to have that blood test positive, not knowing what it means, and sometimes doing excessive tests that are not necessary if the liver enzymes are normal. So there's always a balance of what to do. And of course, if not sure, talk to your doctor about specifics.
At this point, we have come to the end of the questions that were submitted to us, and I appreciate very much those who put questions in the chat, some of which I think fit in nicely what we were already asked. But at this point, we are happy to take additional questions. I think Dr. Silveira and I are eager to see what else are on people's minds. And again, Warren, we're here, so thank you.
Okay, yeah, one of the things that it came to my mind when you were talking about the mindfulness. Again, those folks that contact us on our helpline, very often in their voices you hear frustration. And I think what happens is that frustration comes from when people will say, my doctor, they're doing so many tests and I have to go through so many scans and screening. And, often we will talk to people about the fact that, medicine in general at times is a series of ruling out. And to be able to rule out something, certain testing, has to be done. And there's a level of frustration I think that could cause, not that I think, but that we do hear from people that it's happening. So to go back to that idea of the mindfulness, that might even help with some of the frustration of simply being ill. And where people, without a doubt, it's frustrating having to go to doctors and more tests, and in people's minds, they're not finding anything. But actually findings are happening all the time. And I think very often we want people to know that basically in many ways, no test is wasted, right? Because we are getting information from those, but it can be a frustrating thing. And so not only perhaps could the mindfulness help us with the particular disease we're talking about, but that can also maybe reduce some of the anxiety of illness in general. Is that what you believe yourselves about finding in all this?
Absolutely. We know that it's very frustrating to have a chronic condition.
Yeah.
And even when it has treatment, when you have the URSO and your numbers get better on it, you look good on paper, but you worry, what is going to happen to me in the future? So even when your numbers are good, there's always that little nagging voice. I don't know what's going to happen. You worry for yourself and for your family, for your loved ones. And then, of course, sometimes you look good on paper, but you don't feel good. So you have fatigue, you have itching, and, fatigue, we don't have a medication. So sometimes it's hard to really be focusing too much on that when there's so many other things that you can be starting on treatment. And sometimes we even sometimes give that impression that we're not worried about it, but we are. It's just that we don't really necessarily have an immediate treatment for you on that. So we do focus a little bit more on the things that we do. So of course, talking about it, learning about it, all of those things, participating, knowledge about it, patient advocate groups have been shown to really help quality of life, because you're engaged and you know more about it, and having that connection helps. And as I said, the mindfulness probably works on the brain part of the fatigue, but there's been studies showing that there are changes in the brain that occur with mindfulness treatment, but it also will help in other welcome aspects of stress reduction, anxiety reduction. And again, sometimes the connection, you have that instructor. In our study, for example, you have other patients with the same condition. Being so rare, so hard to find. So camaraderie, going through it together, knowing that the other person's going through the same thing, all of those are things that help. Now, it is important, since there's no particular medication for fatigue, that we make sure they're so interconnected with depression, with other conditions that can cause fatigue, that making sure you're not depressed and that doesn't need treatment, making sure your vitamin D levels are not low and that doesn't need treatment might help, making sure your thyroid is functioning okay might help with fatigue if we find that the thyroid needs treatment. So sometimes, again, we're running a lot of tests, and it's frustrating, but there's usually a logic to it, making sure that nothing is missed. Even for the things that don't have treatment, other things can help.
Mm-hmm. Well, you leave me a perfect opening there for some shameless self-promotion, and that is that ALF has a long standing Facebook group for those with PBC and their caregivers. And this group has been in action for years. There's so many people involved with that. And that's a great place where people can go for support, or as you said, to connect with somebody who may not live around the corner, who might be on the other side of the country, but they do understand what you're going through. And so we definitely encourage folks who are with us in this presentation to please go to our website, the liverfoundation.org website, and look for that PBC Facebook group, because Donna Boll, who runs that group, has been doing it for many years. It's such a great place for support, and we hope that everybody goes to that, again, to try to connect with others in a way that could, help the understanding, or to try to get rid of some of that frustration that you might be feeling about being sick, and specifically about this illness in particular. Yeah. Okay. Well, I think we've touched upon everything this evening. Yeah. I live in New York City, and what you have given us tonight, we in New York call a twofer, and a twofer, like a BOGO, is a 2-for-1, or buy one get one. Now, nobody had to pay anything to join us tonight, but we got double for our money of two really wonderful physicians. And as I read over each of your biographies, what jumps out at me is the word patient. That all the work that you doctors are doing is patient oriented, and that's why you're so special to us, and so special to speak to our group of folks, people who have illness, their caregivers, because it's really patient oriented, and because of your own practice, you can speak so well to those people. So we are very grateful for you this evening to join us in this program. And so on behalf of all of us at ALF, but the attendees of our program tonight, and all those who will be viewing this online, because we will be posting this, as we do with on all of our recorded presentations, on our YouTube channel. So on behalf of all of us, we want to say thank you for being with us. And for everybody, for more information on PBC, other liver disease and liver wellness, go to our website, www.liverfoundation.org. Check out that YouTube channel that I mentioned. And if you have questions, contact us on our national helpline. You can do that with live chat, you can do that email, or pick up the phone and give us a call, because we want to connect with people. We want to be able to help them to understand as much as they can about these things. And a final thank you once again to our sponsors, CymaBay Therapeutics and Intercept Pharmaceuticals, for helping to make this possible. So everyone, thank you for being with us, and we'll see you next time with a brand new episode of the ALF Ask the Expert series.
Thank you so much.
Thank you very much. Thank you.
Thank you, everyone. Okay, take care. Bye.
Thank you.